talking back and forth with Rob, so that's why I'm kind of. All right, so just going over everything. I been looking at some of the grades. Some folks have attempted the mod 3. It's a lot. It's a lot for y'all to take the mod chapter exam on. I'm aware it's a lot. Rob and I have talked about it. It's kind of hard to break it up into different than what we've already broken it up to. Tonight is the night of mod 4, and this is it. This is the last mod we have. So it's things kind of change, things get harder. Registry's right around the corner for everybody. And then your final checkoff is right around the corner. Just be cautious. I'm gonna make this a broad statement that that when you take tests on here, that it's monitored. You go off your screen, you go back on your screen, it flags you for cheating. We've noticed that in one of our mod tests already, so we'll be addressing that. So just be cautious as you go to take these, because that's something that's the same thing as trying to cheat on an exam, because that is your mod exam. And remember, if you go to do this in registry doesn't allow you to cheat. You can't take any notes in. You literally bring nothing. I think they provide the pen and paper. If you need anything, your keys, wallet, cell phone, all that goes into a drawer. You empty your pockets out. They lock everything up, and you're put into a booth with a camera. So you're basically only cheating yourself. If you have been cheating, please we'll address that, because trust me, sorry, I just hit a game with my kids. I get emails on everything that's taken, and they tell me. And if I hadn't been under the weather the past couple of days, I'd addressed it before now. But it is what it is. So we'll be addressing that soon. So starting trauma tonight. So trauma provides fundamental knowledge and provide basic emergency care for transportation based on assessment findings of an acutely injured patient. Why is it just acute when they make that statement? Somebody want to go on a limb and say why? I know I'm asking questions right out the gate. I know that. That's not normal. And y'all are quiet. Y'all just on the road. All right. So acute. It's something it's not chronic. It's something that happens out of the blue. We don't plan it. We don't expect to get trauma. We don't plan it. We don't work on it. It is life or death. You're right. So those are the things that we kind of pay attention to, is that it is acute. It's something that just spontaneously happens. It can be on purpose. It can be an incident. So that's why it's acute injury. We're going to talk about your trauma scoring, how to get your trauma scoring, and why it's listed the way that it is. Your rapid transport destination issues, and what transport mode are we going to use, and why. Is it okay to get a trauma patient and not go lights and sirens to the hospital? 100% yes, it is okay. Maybe it does not warrant to go lights and sirens, but at the same time, it is classified as a trauma patient. That is something that your protocols do. That's something that it dictates. So that's just something that you may have to learn on your own policies and procedures of your agency, but it is okay. I have not always run lights and sirens on all of my trauma calls, but at the same time I have escalated some trauma calls because of it was a patient in the same vehicle and they were both in a traumatic situation. So mine didn't warrant it. The other one was lights and sirens. So instead of getting them 20 minutes later, I just upped my patient and got them there faster. Multi-system. So what are we talking about multi-system? Someone give me an idea when y'all hear multi-system trauma. What are we talking about?
Throughout the body, different organs, limbs, what have you.
Correct. So so if you have extremities and you have pelvic injuries, then you have torsos, or even in a TBI, traumatic brain injury, those are all multi-systems. Is it normal to have in a very bad car wreck maybe a broken leg and two broken arms? Yes, that's normal. Seatbelt burns, yes, that's normal. So, and those are still considered extremities, so those are in the same category, but anything more than that would be a multi-system. So that's where we went. So that was a good answer there. We talk a little bit about blast injuries. It just depends on where they go in here. We'll talk about blast injuries. If not, I'll dive off into that, some personal experiences dealing with blast injuries, and taking one for the team myself. I've been through a blast and had injuries from it. So it's here. It says people younger than 44 years of age, traumatic injuries are the leading cause of death in the United States. What is the leading cause of death in anybody over 45 years of age? Anybody want to take a guess on that one?
Cardio problems.
Cardio.
Oh man, y'all actually learned something. Damn, I'm gonna have to write that down. No, I'm just kidding. Good guys, good answer. So when you get over the age of 65, what is next?
Stroke.
Stroke and falls. So falls and strokes always lead that high end. They always say falls are the biggest, but when you look at it, was it because of the stroke made them weak? So and there's how you classify it, but y'all are on point tonight. So evaluation of the MOI for the trauma patient will tell you some information along with your index of suspicion on types of your different types of life-threatening injuries, what potentially can be underlining, like you may have a broken clavicle because of the seatbelt. Well, you may have a fractured tib fib or a femur because that leg is so swollen and they're complaining of ungodly pain. So some index of suspicion is your awareness and concern for the potential serious underlying and unseen injuries. So here's one for y'all. Maybe y'all paying attention to me before. If you walk up on somebody and they're laying there and one foot is shorter and rotated to the outside, what does that tell you is 99% the problem?
Pelvic fracture.
Correct. You're gonna end up looking to have a pelvic fracture. Either the left or right leg will be shorter and it will rotate to, is that medial or is that what part of the area? Somebody tell me.
It's lateral, right?
There you go. Both of y'all got it. Trying to throw y'all off. All right. So traumatic injuries occurs when the body's issues are exposed to energy levels beyond their tolerance. Well, object in motion will stay in motion. So if you're traveling 65 miles an hour down the road and you hit a concrete barrier, your body is doing 65 miles an hour. So something has to stop your body too. And that seatbelt's gonna kick your ass when it tries to stop at 65 miles an hour, and then that airbag's gonna come out and take your breath away. Yes, they do their job. They are there for particular reasons and they work. Do they cause injuries? Yes, they do. But it's got to stop it. Mechanism of injury describes the forces of energy acting on the body that can cause the injury. Steering wheel, brake pedals, if it's a front end or a lateral, or if it's a end over end, different types there. So here's some of your concepts of energy. You have your potential energy, your kinetic, your energy of work. And energy can be neither created nor destroyed. It can only be converted or transformed. Whew, that's a lot. If you don't know a lot about that, I think it delves into that next. Yes, so work is defined as a force acting over a distance, force that bend, pull, or compromise tissues beyond their inherent transmits resort causes injuries. All right, so I don't know where I was going with that question. I'm just gonna keep pushing the button now. All right, so I don't think this is a test question. Don't hold me to that. I looked at some of the tests today, but I don't think it's gonna ask you what the problem is to figuring out the mass times velocity for the kinetic energy. But it reflects the relationship between the mass of the object and the velocity, which is the speech. So mass is your weight, velocity is speech, at which is traveled equals the kinetic energy. So half of the mass times velocity squared gives you your kinetic energy. Now, I've never had to figure that out in my life. Don't really care to, because I mean, what am I going to do different? How am I going to treat them different? Or is my standard of care or my patient care going to change? No, it's really not, because I can't do nothing about it. And then it says potential energy is the product of mass, force, or gravity at height. So we know that if they're falling, so at 3 times the height of a 6-foot person is 99%, is 90% fatal. Okay, not gonna say that you're not gonna fall in that 10% window, that you're not gonna not die, but you may be injured. But they say anything 3 times your height is 90% fatal. Well, that's pretty serious. So if we're talking about potential energy, that is the weight of gravity and its height. Well, I mean, I think I'm a big boy, even though I think I'm fit and young, which my body tells me that all the time is wrong. So if I go to do something like that, I'm fighting with my body and the gravity. Well, gravity is always going to win. I don't know if y'all have ever noticed and watched some of these dumb fails out there, but gravity, she always wins. So the different MOIs are going to tell you what types of different injuries you have. So, well, what's it say? Injury to an isolated body part, fall without loss of consciousness. Okay, so if they slip, trip, and fall, and you expect that elderly age, they're gonna fall probably to their hands and knees, maybe to their buttocks, and you should expect a pelvic fracture or a hip injury. Now, so it's the same thing if you're thinking about when you get a subject gets hit by a car. Well, you're gonna have different types of injuries depending upon the height of the child. Let's say like if a truck hits a child, they're going to go down and under. If they hit an adult, they're going to go up and over. Now, that is just majority of the injuries that you potentially can see, but you're going to have injury to the isolated part of the body. So we know that, okay, well, we can fix that. So that is a single, maybe traumatic injury to that spot, but we're not talking about multi-system at that point. Even if you get hit by a car, you may not see anything, but you're going to have to worry about those internal organs is our issue. What we're more worried about is making sure that nothing on the inside is injured. Now, again, I can't fix it and I can't tell you what's wrong, but that's the reason why we urge them to go to the hospital so we can get checked out. Significant injuries. Injury to more than one body system. We talked about that trauma, multi-system trauma. Any fall from height. They do recommend 1 times your height, no matter what. Go to the medical facility to get checked out. Motor vehicle, motorcycle crashes. Man, I've seen motorcycles get up and walk away. Motorcyclists, I've seen them get up and walk away. I've scraped several thousands of them up. I hate to say that many, but and just regular motor vehicle accidents. Some agencies still call them MVCs. Technically, it is an accident, so it's a motor vehicle accident, so it's an MVA. I don't purposely plan to collide with somebody. So any time that you have a car versus a pedestrian or a bicycle, gunshot wounds or stabbings, those are all significant trauma that needs to be seen at a medical facility and at the appropriate facility to treat and take care of them. If it's just a regular Band-Aid station and they don't have MRI, CT, and all that, there's no reason to stop and take them there unless they're in a cardiac arrest from the incident and you can't secure an airway. You have to stop at the closest facility. I can tell you, I've been to court twice over one call. Shoot, it's been a couple of years now. A child passed away, and it was such a traumatic event that I was unable to secure an airway because it was, I think this baby had just gotten to daycare. So that's what, 6 weeks old, 7 weeks old, maybe. I was unable to secure the airway. I wasn't startled. It wasn't like something that got me, but I knew that I had to ride into the hospital with this. Well, I couldn't get the airway secured in the other facility. It's 25, 30 minutes down the road. Well, we stopped at a local Band-Aid station that they do have MRI and CT, but they're very basic John Brown Hospital. So we stopped there, got the airway secured, and we were ready to transport. Well, the child never came out of, we never had any change of heart rate. We never got any respirations. There was nothing. The child was deceased when we were transporting it, but he was still warm and dry, and we were ready to transport until he was cold and dry. So that being said, is just because we stopped there, we caught a lot of flack about that. And I wrote my report expecting that. So knowing that was going to be the outcome, even every time I've been to court over it, it's a moot point because I followed what my protocols require me to do. I didn't try to go down the road to a better facility because I was risking my license and my ability, because if I would have got the airway secured, I'd have been happy. But just because you have these simple injuries right here, oh, I gotta go to the other screen, Sensi. So if you have just these simple ones, and they're okay, and we can take them to the major trauma center, but if they go into cardiac arrest or they start going unresponsive and you can't secure the airway, you gotta go to that Band-Aid station. You gotta get that airway secured before you can transport any further. It's just, I can tell you, anybody's protocol is going to require that. Blunt trauma is the result of force of the body can cause without penetrating to soft tissue. All right, so if I strike you with a baseball bat, that's going to hurt like hell, potentially may break a bone, but I'm not penetrating into the skin. Blunt trauma is the result of the force of the body that causes an injury without penetrating the soft tissues or internal organs in the cavities. So I'm still going to cause a traumatic injury, but I'm not taking a knife and sticking you with it, and that's going into your internal cavities. It's just a baseball bat. So that is a type of blunt force trauma. So penetrating trauma causes injury by objects that primarily pierce and penetrate the surface of the body and cause damage to the soft tissues, internal organs, and body cavities. Now, that's saying anything that I can poke you, and I can poke through your skin to poke into your body, that is a penetrating injury. Anything that breaks the skin that goes into the internal body, let's put it that way. And either type can occur from all sorts of different, I mean, I have seen, literally, it didn't happen on purpose, but a dude fell down the stairs at the jailhouse here in my county, and no lie, like he stabbed himself with his toothbrush. It wasn't on purpose. Dude lost his balance. The backstory is, but he just didn't matter. But it was a simple issue. He was like, "Bro, I stabbed myself. I didn't mean to." And I mean, it's something. Now that toothbrushes don't normally, enter the body like that unless they're sharpened and cause harm and all that. But again, it was a simple issue that we got it fixed. It was easy. Done. Signed, sealed, delivered. Took him to the hospital. Got it all taken care of. And I was able to take him without going lights and sirens to a major trauma center. Even though that is a penetrating injury, I was able to stabilize it, and he was stable the whole way there. And we actually laughed about it, and he was making fun of himself as we were transporting him. So that being said, I mean, that's a no lights and sirens traumatic injury. So blunt force. So blunt trauma results in an object making contact with the body. So we talked about that, gave you an idea of what that was, about the baseball bat. Motor vehicle crashes and falls are the most common because your body absorbs the energy from the car, well, like right here. So the car strikes the pole. Your body's still going to collect the energy because it's stopping automatically without cause. A car crash consists of 3 collisions: car against another car, tree, or an object. By assessing the vehicle, you can often determine the MOI depending upon what you see. Walking up on that, I personally would expect to see shoulder pains, maybe a broken arm, and some bruised knees. Not saying that you won't have broken legs. Maybe you could potentially have a pelvic injury or specifically an abdominal injury, because if the driver wasn't wearing a seatbelt and they went up and over to the pole, they could have damaged from the seatbelt, from the steering wheel, and or chest injuries. So right here, passenger against the interior of the car. So this is the driver's side of the car. I'm assuming they cut the steering wheel out and they removed the B post. They did a full extrication. Now I'm gonna tell y'all some experience. I don't know if y'all have ever done this as firemen in your life, but this little pin, this little piece right here that connects these seats, I literally personally, and I can show you, Chris Wally has done this. The Hearst Jaws of Life will not cut that. I'm just gonna let y'all know that. That is a strong piece of metal. So for somebody to actually break the seat, or if the seat was laid all the way back and it broke that way, that's different. But that little pin is stronger than the nader pin that is on this little piece right here. Just gonna tell y'all that. So they removed this so they could gain better access to the patient, because obviously it appears that the patient was in a traumatic situation. They needed as much much access to the patient as they could gain. Now in this one, we are going to expect high impact of injuries, and we're probably going to have some severe traumatic issues. You're going to have chest injuries from striking that steering wheel. You're looking potentially at a flail chest. You're going to have head trauma, because if you look right here, I can't tell if the hood has caused that damage, or maybe their head struck it, and then, who knows. So you don't really, good thing is you don't see a lot of blood all over the place, so that could be a saving grace there. But once they remove this and cut this right here, they have to cut the seatbelt, so you can't ever see if the seatbelt was in place until you can look over here and it was clipped in, because once the seatbelt is locked, it has to be cut. The good thing about older vehicles like this that had the dial speedometer, anytime that somebody was in an accident and they hit at a high impact, it would normally stick at this particular speed. So you were able to be like, wow, they were doing like 85 miles an hour when they hit that. Now everything's electronic and you have the dashes that are, I don't think that's as common as they are, because if you cut power, you still have all those issues. But here, we're looking more of a higher impact. So now we're talking about the coup contra coup effect. It'll probably come up here in a minute. I'm probably just maybe skipping over. So what they're trying to get you to hear is the passenger's internal organs against the solid structure. So right here, the head makes contact with the windshield, then the brain contacts the skull. And then as it comes back, the back side of the brain makes contact with the skull again, and the same amount of force that it did is going forward. Yeah, until you physically see it, or you guys have seen it in the past, you'll understand more about it, which is not saying that it's bad. It's just, it's hard to describe that when you haven't seen this accident happen before, and you can see the literal, a telltale sign right here is you can actually look at the windshield and look for the spidering to see if there's hair attached inside the windshield, and then you know if their head came in contact there. So this is going to be a life-threatening injury because that is a traumatic brain injury. As you know, we've talked about this before. That is our CPU for our body. Every function goes through that brain, either automatic, voluntary, involuntary, functions through there. So if something causes damage or issues to that, we now have our hands full. We need to get them to the closest facility, or to the closest trauma related facility that can do them the best the best of the best in a reasonable amount of time. Significant MOIs, death of an occupant in the same vehicle. So if a driver and a passenger and the driver dies, it is a high suspicion that the passenger has life-threatening issues at the same time. Even though if Granny is 85, 99 years old, she's driving and I'm my happy fat 41-year-old self and she dies from the accident, it's yes, that's still because we're gonna go with the idea until proven wrong that you would expect me to have severe internal organ or internal damage. Now, later down the road, we can be like, well, you know, she was 99 years old, so we go from there. Severe deformity of the vehicle or intrusion to the vehicle. We used to have in Central Mississippi, we used to have a protocol that said if there was greater than 3 foot of intrusion inside the vehicle. Now, 3 feet is a lot. So I think that kind of got gone because that's what, 36 inches. Well, that's a lot. At the same time as, yeah, it could not be a lot depending on where the accident occurred or what was hit. So that being said is now we just go off of the MOI and we look for what is presented to us. Just how is the patient, and we go off their GCS, their glaucoma score. So that's what we shoot for in the Central Mississippi areas now. Severe damage from the rear. If the trunk is now permanent resident of the back seat, that's severe damage. Crashes in which rotation is involved. So if they went round and round and round in the intersection and ended up on the other side and they rotated 4 times, that's significant MOI. Ejection from the vehicle. Now, we mean injection while the vehicle's in motion, not that they were thrown out because the vehicle tipped over and they fell out the open windows to escape. That's not ejection. Now, at the same time is if you ask the question, what's the last thing that they remember? And they said, I don't know where I'm at. Well, right there, you have altered mental status. So that right there is going to make your case to take them to a trauma center a lot higher, and you want to transport them a lot sooner because that's a brain injury. You're looking at a contusion, a concussion, possible internal bleeding. So those are the signs that you have to dig for when you start asking questions. If they say that out of the blue, or if they start asking the same question over and over, it's time to go. We got to go. Evaluate supplemental restraint system. Determine whether the passenger was restrained and whether the airbags were deployed. So if they were deployed, it's going to tell you a lot of things. And sometimes they'll tell you if airbag deployment, we want to make sure. But what we want you to do is, let's see here, determine whether the passenger was restrained by a full and properly applied 3-point restraint system. Now, 3 points is your seatbelt. They restrain 2 points on the bead post, and then when it comes around you, it locks in to a 3rd point. So that's your 3 points of securement. Determine whether the airbag was deployed. Seat belts and airbags are effectively in preventing a second collision inside the motor vehicle. Seat belts may decrease the severity of the 3rd collision. Airbags decrease the severity of deceleration injuries and decrease the injury of the chest, face, and head. It's not saying that they won't. Sorry, my he's getting ready for prom this year, and he is freaking out. So my son, it's just khakis. He can't get over it. Couldn't go with him tonight because I'd teach some good folks. So just because those airbags they shoot out, freak, I forgot how fast they come out. I used to remember, like I used to know that in the back of my head, but they still can cause injuries. They can still create issues. They can still cause an injury on the patient. So still expect that at the same time. Next. Despite airbags, you may still have extremities and internal organs from the second and third collision. Now, the picture that I'm trying to get to is pretty impressive. You guys hadn't ever seen one of this before. So remember, any child shorter than 4'9". Now, I'm not picking on nobody. I have a friend of mine. She is literally 4'9", and she's a grown woman. And I'm like, girl, you gotta get in the back. You gotta sit in that car seat. She hates me every time I see her. I tell her she's always grumpy and she's in a bad mood. She walks around smelling booty holes all day because she's so short. But she's a jam up good friend of mine, and I can say that, and I'll joke about her if she was sitting right here. So remember that if the airbag did not inflate during the accident, it may deploy during extrication. So if the fire department is there and they say, hey, the airbags, the power has been cut to the vehicle. So knowing that, you can still have up to 30 minutes for that airbag to deploy. That being the case, be cautious. Do not stick your face, head, or body inside the vehicle during that time. Some agencies do have airbag seatbelts, is what they call them. It's a contraption that wraps around the steering wheel. There's also some type of contraption that also locks and secures on the passenger side. But you have to be careful now, as every vehicle starting to come out with these side curtain airbags. And I'm gonna tell you, they're gonna knock your teeth out. You get up in there and get hit by it. So the best thing you can do is just go reach in with your arms and all that. And when it's time to move the patient, move them out pretty rapidly and get away from the vehicle so you can turn around and do that. You can take care of them once they're outside the vehicle. Life over limb, but be cautious. Let's be smart about that. Let's not just jerk them around just so we're like, oh, I was afraid the airbag's going to come out. I just want to make sure we were okay. And you're like, well, the airbag's been off for the last 45 minutes, so just be cautious on that. Look at here. So this is the typical seatbelt injury. That's typical for us, that we're gonna see. I mean, he's a big boy, and look, it appeared that he was going pretty fast. I don't know about y'all. I've always joked here. It looks like somebody had a hand right across his chest too, but now it's got some broken fingers. But no, I mean, who knows what that's from? As you can see, he's pretty bad shape. He is probably listed as a trauma patient. You see bilateral 18 gauges. I can tell you because of the color. Got a good 4-lead running. I got T-boned a couple years ago, and the bruising took over. Yeah, and I guarantee you were sore, Caesar. I bet that felt like you got smoked by a train, I'm sure. So this dude's probably a trauma patient. There's your money collar right there. So be cautious of that. And anytime that you're worried about that, always put those money collars on people. I call them that because everybody that walks around and wears those gray ones, I mean these silver, these old tan ones now, those are all money collars. So every C collar has been changed to a money collar to me. Just be cautious, put them on that C collar. It's always better to let somebody take them off later down the road that's a little bit more trained and they can do x-rays. And then a lot of agencies nowadays have taken out the procedure of putting people on backboards unless they complain of back injuries. If the patient complains of back injury or is not standing at the time of your arrival, you may have to put them on a backboard. But if they're up walking around on the scene when you get there, that's most likely indicative that you don't have to put somebody on a backboard when you start ready to transport. It's not saying that they were not when the adrenaline wears off and they're like, oh god, what is all this? And the pain starts. That could be normal, and you can easily put them on after that point. Look for contact points between the patient and the vehicle, so you perform a simple quick eval of the interior of the vehicle. What is in there that I can see that made contact with him? What possibly caused injury? Now, I tell you, I'm a big picture guy. I take pictures as I'm arriving on scene, as I'm walking up to the patient's vehicle. I take pictures of all the vehicles, interior and interior and outside, because I can attach those to my report of whichever patient that I get out of the vehicle. Now, if I have two of them, obviously that's two different run numbers, but you can attach the pictures of the program that we use in my little local ambulance service. So I'm sure there's other agencies that do about the same thing. So pictures are wonderful. Now, remember also is when you do this, and you can take those pictures back to the medical center and show them, be like, look, this is what I'm trying to tell you. This is what we came from. So they may be pretty serious, and the hospital's like, whatever. And then you show them the pictures, they're like, oh, all right, I got you. So here you're looking at potentially greater than 3 foot of intrusion of the vehicle, but there is major damage on this vehicle. Now, and another thing I can tell you is the frame is bent on this vehicle, so it is automatically, it's totaled. So that is a high-speed collision. Any type that you see a frame bent, or part of this, the rear axle or the front axle or the arms and all the tires broken off, that's a high-speed, high suspicion of injury. You're gonna have back and neck pain from this no matter what, and I'm gonna tell you, you cannot prove that back pain is not present. That's no matter what, it's muscular. You can take as many x-rays and nothing's there, but they cannot prove that a back injury is not there. That's why there's a lot of investigations out there these days about people trying to scam insurance companies on back injuries because you can't prove them. As the body is propelled forward, the head and neck left behind, acceleration type of injury to the brain is possible. Passengers in the back seat wearing only a lap belt may have a higher incidence of injury to the thoracic and lumbar spine. Because remember, a lot of your vehicles now on the outsides, I say the door seats, do have lap shoulders. The ones sitting in the center are only going to have laps. Some vehicles do still have the 3 points of contact. I know, like my wife's 4Runner, we have that. We have 3 points. So even in the very back. So some vehicles will. Isaiah, questions before, I forgot to determine MOI in a multi MVC. Do you go off the area of the most damage being? So when you look at that, if you're saying you're trying to figure out what the MOI is based off the vehicle, is that correct? All right, so it can be a multi-system trauma, because if you're just like, bro, this vehicle is trashed, like I don't, they hurt no matter what. So you can classify it as, a multi-trauma system because of the vehicle is mangled far enough you couldn't make out the make and model of the vehicle. Now, would that be the case? Not 110%, because you're trying to relay what you saw to the facility over a radio, and you only get 25 words or less because we're not going to listen to you after that. So trying to determine what your MOI is, it may just be easier for you to list multi-system trauma and do however you write your charts, as you can be dashed, left arm, right ankle, right shoulder blade, and just kind of list them out like that for your report, for your facility report, or for your ambulance report, because you need to encompass what was wrong with them. And then now you got to start assessing all those, and that's part of your report that you want to go further in detail, is to let them know that you assessed it and worked on it for every part of it. I mean, I know that's probably more than what you asked for, but sometimes it is just hard to look at a vehicle accident and be like, bet you they're going to have a broken arm, and you're like, oh, y'all didn't have nothing wrong. So they will give you some suspicion, but on some of your more mangled ones, it's kind of harder to tell. You may just say multi-system and go on from there, and then detailed injuries as you go in further. So here, side impacts. So very common cause of death associated with motor vehicle, because you think about it, this is a T-bone. You're getting the bumper in your teeth. That's really that's the easiest way to look at it. Their bumper is striking you in the face. So it doesn't matter if you're higher than they are or you're lower. It's still an idea. You're knowing where the impact's going to be. So that being the case, I'm more of I want to investigate a lot on T-bones because they have a higher cause of death than the other MV parts of them, unless you start talking about ejections and stuff like that. So, just do a really good assessment on any of your type of your MVCs, MVA, sorry. So you can, well, there it says right there. In a lateral crash, the car is typically struck above its center of gravity and begins to rock away from the side impact. This causes a type of lateral whiplash in which the passenger's shoulders and head whip towards the intruding vehicle. So they could turn around and strike themselves on the hood of the vehicle. They'll go away and then they'll come back. And when they're making that second impact, it could be potentially on that vehicle itself. So, a vehicle, hold on. So you have 3 minutes to give a report to Telcom, which gives your report to the ER department. So, is that what y'all do up in Memphis? Wow, that's 3 minutes is a lot. I give I'm normally like 25 words or less. I'll be like, I'll give you full report on arrival. Coming in, lights and sirens, got a multi-system trauma, rollover, MVC. 27-year-old male, vitals are done, and that's basically my report. And I'm sure Telcom is probably like your dispatch. Like we use Medcom. That is our big facility here in Central and Mississippi. Period. They handle all of our statewide disasters and stuff like that. So, and yeah, okay, it's kind of the same thing. That's what I figured. So you call in a report to one area, and then they turn around and they relay what you're bringing into the appropriate teams. Like if you need a neuro team, so those help instead of tying up the time with the nurses or anything like that when they start trying to answer the radio. So medcoms could be a central dispatch for the hospital, whatever your area calls them, but they play very vital roles. But it's always been that I've always been told, try to keep it 25 words or less. If you have two patients, it's 25 words or less for two patients. And the reason why I stuck with that is because I started out in the law enforcement and the paramedic world and the firefighter world. Nobody wants to hear you after that because they've already given up on you because you're talking too much. Am I right, Reginald? Because y'all hear that crap all the time. And you're like, would you just shut up? I'm trying to give my report. So the more information you can push out as fast as you can, the better off you are. A vehicle struck from the side is usually struck above its center of gravity. We'll talk about that one later. If substantial intrusion into the passenger compartment, suspect. So anytime you have any major intrusion into the vehicle, and I'm gonna say this period, always suspect chest and abdomen injuries on the side of the impact. Now, if that's a lateral crash, yes. Possible fractures to the lower extremities, pelvis, and ribs. Organ damage from the third collision. Now, because that's a soft tissue, they can't. When I say they're not hard, and the reason I'm saying that is they're not tough. You can abuse your organs, especially your kidneys or your liver if you drink a lot or not, but they don't build up scars and say, I'm good. No, once they take damage, they die. That area dies. So they're very weak, and you start messing with your organs and your heart and your lungs, you don't normally tend to come out in the favor to say I'm sorry later. You tend to have them removed and you pass on to whatever life you have. So be cautious of those, and make sure that when you're dealing with these types of patients that are from these lateral crashes or the rollovers, that you go ahead and suspect that, because that's potentially an injury and an issue that you're going to have to report in and say, hey, I've noticed the abdomen has started swelling since coming in contact with. So that's probably telling you that you have bleeding inside the abdomen. And no, there's no way that we can tell from that, but you can monitor their blood pressures. If their blood pressure has changed, or you've noticed the abdomen becoming from soft and now it's firm and rigid, that's telling you different types, that there is some type of blood that's pulling up in there. So be cautious of that. That's from an internal organ injuries. Possible lower extremity fractures, pelvics. Those are gonna be not all the time obvious, but the patient's gonna let you know, I don't know what you're doing, but it hurts. And you're gonna do it one more time, and then they're gonna tell you, hey, that hurts. My leg, I think it's broke. And you're like, oh. So those will tell you your internals, your non-seeing, the ones you can't put your hands on, those are the ones that are tricky, because like in the paramedic world, I have to be cautious on the amount of fluid I give them, because I can bleed them out on the inside of their from their thigh, from like a fib fracture, or a femur fracture, sorry. And then a pelvic fracture, you can hold 3 liters in your pelvic. So you guys to be very careful about that. And notice they were like, oh, blood pressure's changing. What's going on? Something's up. So be cautious of those things and make sure what you're doing is very cautious. Rollover crashes. So these are, so large trucks, sports utility vehicles are prone to rollovers because of their high center of gravities. Now, I'm not going to say that it's not just that, but you can have low center of gravity cars get hit. I've actually seen a Corvette go end over end when a Toyota Tacoma hit it. It just happened to be the way it hit, how it hit. It was it was one of those, like, how did that happen? The way that Corvette was turning, and when the Toyota hit it, when it went rolling over, son. It was weird. Spins separately to the rollover. Rotation of the vehicle provides opportunities for the vehicle to strike objects such as utility poles, because again, they're just going uncontrolled, rolling, rotational over down the road. They have you can't turn your steering wheel and potentially miss it. Once that energy is applied, something has to stop it or absorb that energy. So until it does that, it might be the pole, or it might be the big tree down the embankment. Now, some of your injuries from car versus pedestrian are going to be very graphic. They're going to be nasty. Those are the ones that you're going to be like, oh my God, what? Like, I didn't know that that meat was white. It's nasty. The open bones, your open fractures, you may see brain matter from a skull fracture. So all those things you have to be cautious about. And sometimes when you hear car versus pedestrian, it may not be as bad as it is because of the speed of the car. Until that is determined, and you get there and they're like up and walking around, be like, yeah, I had literally just pulled out of the parking spot and struck them from behind, something like that. It's still considered a vehicle versus pedestrian, but and then knowing if the patient was thrown in the air or not. If they were not thrown in the air and they stayed in contact with the ground, that's a big thing. That is another thing, knowing that gravity didn't try to win again, because the surface can cause a lot of injuries. Where did they land on concrete? Did they land on grass? Brick? Those are some of the things that it'll help with determining some injuries also. Whether the patient was struck and pulled under the vehicle, so the down and under. Now that you may have, or is the vehicle still on top of the car? That did not make any sense at all. Is the vehicle still on top of the patient, and now they're not able to get out? That's a severe issue that you need assistance. You've seen it multiple times on TVs. I know you have, where that's happened, and the bystanders just are able to pull the patient outside out from underneath the vehicle because they've lifted the vehicle up. That's great. The bystanders are wonderful. They did the job. They helped, and it's life over limb. I would never tell them that they did a bad job, but just think that's something that you're going to have to deal with when you get there. So knowing where they were is a big information. Hey, where was this patient? Oh, they were underneath the vehicle, and we all pulled them out. Wait a minute, y'all did what? You're not fussing, but at the same time as you're like, oh wow, so they they were entrapped or they were pinned underneath the vehicle. Yes, that's what we're trying to tell stuff like that. Pay attention. Hang on a second. Rob just sent me a message. Let me see what he says. All right, sorry. So evaluate the vehicle that struck the patient for structural damage. I don't care if they've got a broke fender, but you need to see where at on that vehicle is damaged. So if they only have damage to the windshield, that potentially can tell you that they hit and landed on the windshield, or that the patient jumped and struck the windshield itself. If you're running a basic truck, ALS backup should always be summoned for any patient who or have thought to sustained multiple MOI. So that's something that you should always have them come in. If you at least alert your dispatch, be like, be advised, see if you can get an ALS unit to slow roll this way until we get there and confirm. We'll let you know further. It's easier to have them en route than it is to not have them coming at all. That's the scary part. Let's see here. Evaluate like you would for a car versus pedestrian collision. Evaluate the damage to and position of the bicycle. If the patient was wearing a helmet, inspect for damage. Always take the helmet with you if you have to remove the helmet, but a lot of times it is safe just to leave the helmet in place unless it provides, you're not able to gain access to the airway. That's when we want to get in there and try to figure out what's going on. Look at where they were struck to where the bike landed. If it is greater than 5 to 7 feet, know that as a major trauma issue, and we'll work from there. Because just knowing and stating those that's the big issue. Is like, I need to know where and what and how, and those help you when you start getting to the hospital and documenting that information. Presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise. That is true. We don't know. We are in the field. We cannot make those decisions without X-ray. Always spinal stabilize must be initiated and maintained during the encounter. If I mean, heck, I even put C-collars on my cardiac arrest patients. Once I've intubated them, it's really good. It holds my tube in place. I don't have to worry about the head moving around. It's easier for me. That's something that I've always done and gotten in the habit of. One of my educators told me years and years ago, that's what they suggested, and it works great. So I've stuck with it. And it's really weird. You get to the hospital and they're like, why is there a C-collar on him? I thought it was a cardiac arrest. Well, if I have to explain to you why it's there, then I don't need to explain to you. So I guess I'm kind of that guy. I don't mind being smart with it. Car versus motorcycle, boots, leather, gloves, anything like that. Those riding onesies. I don't know what those are called. I don't ride bikes. But leather or their abrasion resistant clothing. Those are all safety items that need to be noted and brought to the facility with you, because it helps the doctors. It helps them determine the mechanism of injury and how bad potentially that it can be. Now, granted, they're going to echo your heart. They're going to use a sonogram and all that to see if there's potential organ bleeds. They're going to do all these cool things, but it's just at the same time as it helps to bring as much as you can with you, just so it helps them treat the patient better off of certain findings that they come across. When assessing the scene, you want to look for a deformity in the motorcycle side of the most damage. So that'll tell you where they hit from the left, right, front, or back. And I'm sure if it's bad enough, there's going to be a substantial damage throughout the vehicle. But trying to figure out if it's on the left or right would be really important. Distance of the skid on the road, deformity of the stationary objects and other vehicles, extent of the location of deformity in the helmet. Um, that's why I say always bring the helmet with you if you have to remove it. If not, try to leave the helmet in place and just pad it as like it's a C-collar in itself. You may have to roll up towels or some form of fashion to keep that helmet in place and keep it from flopping around as you go. Deformity in stationary objects, like if a pole was broken in half or they ran into, they were pushed into the bike was pushed inside of a building or something like that. Was there intrusion of the brick? Things like that. What we want to look for. Deformity of the motorcycle, man. I mean, I've worked many of motorcycle wrecks. There's always types of deformities on motorcycle wrecks. So I've worked police officer motorcycle wrecks, civilians. I mean, there's always something that's broke on that bike, but the severity of it will help you to get some determination of what is wrong and how bad it was. So here's your types of crashes. You have your head-on, your angular crashes. A lot of these will make sense and tell you what they are to begin with. I don't have to explain a head-on crash. An angular crash. The motorcycle crashes an object and strikes an object or another vehicle at the angle so that the rider sustains direct crushing injuries to the lower extremities between the object of the motorcycle. So it's like if they at this side, that's a T-bone in my eyes, the way that I'm looking at it. So that's just how I'm gonna roll with that one. Ejection, I'm pretty sure they're gonna be ejected a lot of the times. That's probably 90% of the time that even if they laid the bike down, they still were ejected from the vehicle because they don't have no seatbelts on them things. Control crash, that talks about a lay down. How was it done to lay the bike down and they were to push off from it? I know some of our police officers are taught that. I don't even know how you teach that, but if they can, that's how they're supposed to. I mean, I don't know. I just know what they do. Falls. Injury potential depends on the height at which the patient fell. More than 20 feet is considered significant. Internal injuries pose the greatest threat to life because we can't see them. We can't fix it. It's hard to stop bleeding on something that you can't see. If you know it's there and you see it bleeding, I can apply pressure. I can fix that. But the internal, the busting of the spleen, that's hard for me to fix because that's all through surgery. That is not what Chris Bobby's gonna fix because I can't. I can just get you to the best facility for the outcome that's needed or that's wanted. So be on suspicion for high injury on depending on the greater of the fall. Patients who fall and land on their feet may have less severe internal injuries, but due to the shock absorption, their legs may absorb much of the energy of the fall. So now you're going to see right here that they're going to have potentially femur to pelvic to lower back injuries. They may blow their ankles out also. I've seen them blow the ankles and the tib fibs. That's actually running from the cops. I was actually taking care. He didn't go too far. They found him. He was hollering. He did it on both legs. It was all he did not have an open tib fib. They were internal, but it was very obvious that they were blown out. And that was falling from greater than 20 feet. But he landed on his feet, or he attempted to, and didn't go far. But take the following factors into account: the height of the fall, type of the surface that they struck, and the part of the body that hit first, followed by the path of the energy displacement. So what kind of surface is a lie? So if it's a hard concrete packed surface, or is it loose dirt? Is it water? You know, is it something that can absorb that energy or push it out the way? It's easier to fall. Now, water's still going to hurt you, and water's still going to cause injury, but at the same time, it may be softer than landing on a pile of bricks. So consider those. Whew, that's a nice one. I'll tell you what, we'll leave it on that slide and we'll start right back there in 10 minutes. At 11 after, we'll start this penetrating injuries off. All right, I'll see y'all in 10, folks, and we'll start with questions too. All right, bye. All right, since we've all sat here and stared at this wonderful janked up knife in the center of his chest, or the left side of his chest, what questions do y'all have regarding what we've already been over? All right, I guess that's solid saying you got it. All right, so penetrating injuries. So now that that's anything that intrudes the skin, okay? So let's remember that. So that being said, stand by. So this is going to be your second leading cause of trauma deaths after blunt injury. Now, let's remember that. So as we go through here, we'll talk about that. So penetrating trauma is the second leading cause of trauma death in the United States after blunt trauma. Low energy penetrating trauma may be caused by accidental by impalement or intentionally by a knife, ice pick, or other weapon. So obviously here, this patient got stabbed and appears it's, I'm trying to figure out what that is right there. I think that's the least of his problems, me trying to figure out what that is. But he seems like he got it pretty bad. All right. So with low energy penetrations, injuries are caused by the sharp edges of the object moving through the body and are therefore close to the object's path. Knives may have been deliberately moved around internally, causing more damage than the external wound suggests. Now, let me see if I can ask y'all a trivia question. On knife stabbing patterns, which way do women stab? Anybody want to guess?
Down.
That's correct. You watch murder mysteries too, don't you?
Yes, I do. A lot of them.
So men stab up in the upward motion. Women stab down due to the height. That is the normal way that those are the normal stabbing patterns. Now, as long as the object stays in place, the better off it is. Now, if you stick the knife, you jab somebody, and you go to wiggle it around a little, and it just doesn't exit as fast as it came in, you potentially, if it goes in and comes out, it can potentially seal itself off, but not common. If you use a certain type of blade versus, let's say, a straight razor blade, just super sharp, or you use a kind of like a saw blade, you're going to have different types of pattern injuries and more likely to be susceptible for other injuries upon the type of blade that you use. So it's always good to say, where is the knife or the weapon that was used? Ice picks, those are easy to take care of. They're very hard to see, but make sure if you have a trauma patient, look and expose. I'm telling you, look in the underarms. If they've been shot and you can't see any visual, it's probably been closed. And I've seen that happen with knife injuries too. Path of projectile may not be easily to predict because it's not. You don't know. Bullet may ricochet within the body before exiting, depending upon the caliber that's shot. Now, if you see casings on the ground, that's most likely from an automatic. If you don't find any casings, that's going to be from your revolver, or your person has been really good at picking them up. No, I'm just kidding, but that's 90% of how your shootings are. Path of projectile takes its trajectory, and fragmentation will increase damage. So unless you're so your full metal jacket bullets, those are the ones that you take to the shooting range. Those cause a lot. They still cause damage. Okay, so let's understand that. But they cause a lot less damage than your hollow points or your no matter what, they're going to cause a lot more damage because when they hit, it's the same thing as shooting with a hunting gun. Is when they shoot, they blow open. Full metal jackets hold their shell until they make contact with the metal or a plate or something like that, and then they bust into fragments. But the fragmentation of a hollow point peels out and sometimes can pull off of the bullet itself, and that's where some of the other damage can cause from. There's several different types of bullets out there. Um, Damn, I was gonna say it was because we were short. So those I like watching investigations, and when they do autopsies on looking at the bullet, the patterns and all that. To me, because I enjoy shooting, so it teaches me a little bit. No, I'm not trying to plot or anything like that, but I would tell you if I killed somebody, I'd use a bow and arrow. No, I'm just kidding. I'm not gonna kill nobody. I look good in orange. I just don't ever want to wear full orange the rest of my life. So that's my story. Um, that is the mafia round. That is because they bounce around so much, and they all over the place. So cavitation results from the rapid changes in the tissue and the fluid pressure that occurs with the passage of projectile. Temporary cavitation injury results from a stretching of the tissue that occurs with the pressurized change. Permanent cavitation injury results closer to the bullet path and remains after the projectile has passed through. Whew, all right, so here's our bullets coming this way. So as it's coming in, this is the reformation caused by the elastic tissues. It starts to open up. This is where we have our temporary cavity right in here, because it's the force is pushing it up and down, and then your permanent cavity is because that is the bullet itself that has stayed on track. You notice it's really small here, and then it starts to fatten out, and it gets back to the normal size, and then it stays that path until it strikes a bone, a plate, or something like that, and that's where your temporary cavity and some of your other cavitation will come down. You will have trapped blood in here. When they start to have surgery and all that, you'll see some of the coagulation up in here. But this one right here is what's going to have to be sewn back shut. So, relationship between distance and severity of injury varies depending on the type of weapon involved. I can shoot you with a 9mm revolver and versus a 9mm carbine. They both fire at the same amount of feet per second, but the injury pattern, most likely if you get shot by a 9mm pistol, you're going to be within average shooting is anywhere between 5 to 7 feet, versus if I shot you with a 9mm carbine, I can be up to 300-400 feet away. So you're looking at your severity is going to be a lot more with the distance. Air resistance is often referred to as a drag. So if you start to shoot, you will have the drag by the air that can affect your bullet pattern. It slows the projectile, does decrease the depth of the penetration and energy of the projectile, and thus reducing the damage of the tissues. So ultimately is the plan to have the most perfect shooting weather every time, but that doesn't happen. We fight with the heat, the cold, the wind, the crosswind, and all that when you go shoot. And the same thing for hunting or sports shooting or anything like that. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile itself. So a 22, as Caesar pointed out, that is one of the smallest bullets that is out there on the market. Now you can go all the way up to a 50 BMG, which is one of the largest bullets that's what's not known to man, but is largest and the accessible to civilians, I'll say it that way. So when you start talking about that, now shooting somebody with a 22 versus a 45, a 45 is a fat bullet, it's heavy, it does drop faster than the 22, and the 22 can go further, but the velocity and the kick that between the two is what the 45 is going to cause more damage and will kill you faster than that 22, depending upon the distance that is shot from. There is one reason, this is one reason that the exit wounds are often many times larger than the entrance wounds, because of the high velocity, low velocity. The energy available for a bullet to cause damage is more a function of its speed than its mass. An important factor for the seriousness of a gunshot wound is the type of tissue through which the projectile passes. Was it through the arm? Was it in the belly? Because now if it's in the belly, you got to worry about the when we just talked about I just went blank. The cavity, what did it go through? What type of tissue? Now your organs and tissues are going to have damage because of all this, the cavity and the flow of pressure. So the pressure change is going to cause injuries also. The energy that just went through there, the organs are not going to handle that very easy. And I actually talked to a trauma surgeon in our area that said we don't have more deaths by shooting because of cheap ammo. If they spent good ammo, we would have more deaths. So that was her output, and I just kind of laughed because I was like, well, I can't argue with that. But so
I have a question.
blast, yeah, come on.
So obviously, if you get dispatched to a person that has a gunshot wound, then I know you're gonna want to, well, I guess it all depends on how it gets dispatched, but of course have police there to make sure that the scene is safe. And then I guess what my question is that, how important, I'm sure it is important for the hospital to know, but if you're just trying to hurry up, load the patient and go, you don't have time to figure out what kind of bullet penetrated your patient. And so and I know, of course, a 22 versus a 9, that's a different story because 22 bounces around. But I mean, how important is that going to be right then and there?
For your treatment level, nothing. You're still going to treat it the same. You're still going to treat the ABCs.
Right. But as far as relaying the information whenever you get to the hospital or on your way to the hospital.
You can just tell them it was a shooting, unknown caliber. My prime example, I can tell you this: a good friend of mine just worked a shooting 2 weeks ago in our area. Boyfriend and girlfriend were fighting. Literally, she hits the desk that the gun was laid on, and when it fell, it went off. Well, they both fell to the ground, and they were like, "Oh my God! Well, what just happened?" When she looked at him and says, I don't feel good. Boom, she went out. They worked her as a cardiac arrest. They sent her straight into the hospital. The only way that they knew that she was shot is when they didn't even find it in her shorts because where she got shot at didn't go through the clothing. When they were going to put a catheter in her, the nurse just happened to notice a little bit of blood on the bed, and they were like, where did this come from? Well, what's the deal? She got shot when the gun went off between I don't even know what it's called, the crease between the butt cheek and the leg. And it was on the inter leg close to her female area, and it killed her, and it was a 9mm. Never made it past the abdominal area. Killed her on the spot. She was 22 years old. So they didn't even know she was shot. Had no idea. But because they didn't find no hole. And I mean, I'm not gonna go dig in somebody's crease of their butt to see if they've been shot because I'm just gonna work it as cardiac arrest. But knowing that now, and you're like, wow, oh, okay, well. But knowing the caliber is not, it is important if known. If you don't know, just be like, I mean, it's the same thing. If an officer gets shot, I don't know what size he got shot at, or what they were shooting, but I know he's shot, and we're going to treat and transport. Your care, the hospital's care, once you get to that point, they're just treating the injuries at the same time. Once they pull the bullet out later on, they can tell and be like, oh, now we know why we had so much blood. We had a 7.62 round in there versus a 38. So it's kind of, to answer your question, it's kind of a twofold. Yes, you want to know, but if you don't know, it's okay to not know. You know what I'm saying? Does that make sense?
Yeah, that makes sense. So I take it it nicked her or at least severed the femoral artery.
I have not heard what he said. He was going to ask about the autopsy, but I would assume that it did, but I mean, I truly hate it, but I mean, it is what it is. I mean,
Yeah,
I
that's
mean,
a
it's
unique.
it's it's weird. You know, you could talk all day long. We could give y'all that as a topic when y'all go to work your patients. You wouldn't. I mean, I'm not setting you up for failure, but that's one of those. 20 years into this, I've not like, oh wow, that's new. You know.
Right.
All right. So blast injuries. Um, we don't really see many mines anymore, and they're not talking about like ground mines. They're talking about like coal mines, shipyards, chemical plants, terrorist attacks. Majority of what we see these days are terrorist attacks. That's really been our biggest one, unless y'all can think of any other explosions here lately that have not been caused besides terrorist attacks. I mean, you had your that reactor in Japan that failed. That was from a chemical plant, but that's, I mean, hell, that's on our west coast now, affecting all the fish out there. I mean, so terrorist attacks is kind of our number one thing when you talk about blast injuries. Um, heck, I could show age, and I remember the Atlanta bombing from the Olympics. Um, so this is pretty cool. Let's talk about this. So here's our primary blast injury right here. So this is your initial blast wave. I don't know why my cursor's so small. It takes so long. That's your initial blast wave. All right. The next one is going to be your secondary blast wave. This is injuries due to the missiles being propelled by a blast force. Now, if we put washers, nuts, screws, bits, whatever those are projectiles that's being injected into this bomb, in or around. Pipe bombs, same thing, you can type them around there. So you talk about your tertiary blast injuries. So that's injuries from impacting other objects. So if I blow your door off and you get from this and the door hits you, that's a tertiary injury, okay? Now, coronary blast injuries, collateral injuries such as burns, okay. So any type of injury that's caused from the blast. Let's say there's a burn injury, toxic inhalation because of the smoke, or if we put chemicals in there on top of it. That's where that's coming from. But majority of the time, you're going to treat your primary, secondary, and tertiary blast injuries unless there is a toxic that's involved into it, that's been wrapped into it and creates that issue at the same time. So those are not, I mean, right now you're seeing a lot of the tertiary and the chemical exposures. That's kind of the chemist that are involved in these bombs, like the Boston bombing. They used the crock pot bomb that had washers, screws, bolts, all that glass and all that was in there in the crock pot. So they didn't use chemicals. So your primary blast is due to entirely to the blast itself, damage to the body by the pressure wave. Secondary blast injuries, damage to the body results from being struck by flying debris. Tertiary blast injuries is the victim is hurled by the force of the explosion against a stationary object, a wall, a curb, a partial wall, a pole. All those are tertiary blast injuries. It's the same thing as being an IED. So if you get hit the initial blast, you hit that. That's what takes these the injuries that happen. The tertiary blast is when that soldier or individual strikes the ground, strikes the armored vehicle. The solid subjects, the solid portions is what strikes them, and that's what causes those injuries. Your miscellaneous blast injuries, burns from hot gases or fire started by the blast. That is a non-intentional, like we did not mean that to happen, but that's what's happening. You get your respiratory injuries. because you're going to see up now. So the respiratory can be from the blast itself and from the toxic fumes that come from the blast. Crush injuries from the collapse of the building. If it's that big, like we talked about Atlanta, Atlanta did not happen. A lot of people got injured. I actually said it was one of the workers that were here. Oklahoma City bombing, all three of those happened along with the crushing injuries from the partial or the collapse of the buildings. You know, there was a lot of children that were involved into the child care that was there at the same time. You are going to see at least two of these at all times. You're not gonna just like, oh, well, I got one, I'm done. You know, so you're gonna have a combination of all of that. Organs that contain air are most susceptible to pressure changes. You're gonna have blown ears. That's where you have people trying a hard time to hear. The lungs, the respiratory, like, I can't breathe. Oh my God, it knocks the air out of them. Your gastrointestinal tract, you're gonna have issues there to where that may be down the road where you urinate blood for a while. You may have had a little rupture and you have trouble going to the bathroom, or if you do, you get, you know, a swelling or an infection. And that can all be from your blast injuries. Your pulmonary blast injuries are defined as a pulmonary trauma that results from short range exposure of the destination of explosives. Pneumothorax is common injury, as requires emergency decompression in the field. That's where you take the needle, poke it between the second and third intercostal, and you hear lets that go. One of the most common concern in pulmonary blast injuries is arterial air embolism. So it's APE. Sorry, that's arterial. So they're talking about higher, which occurs in the alveolar disruption, which the having trouble saying that. So you're caused by an embolism into the pulmonary vascular area. This disturbs the visions. It changes in the behavior because now you got a TBI. You've had injuries to the brain that may affect the vision area. You have changes in the state of consciousness. Are they responsive? How are they? What's going on? You know, I need to know, hey, what's the last thing you remember? And then a variety of other neurologic signs. I've seen where they go to, they still think they're in the fight. You got to take their weapons from, or you unload their weapons, you clear them, and you give them back to them, make them think that they're still in the fight, so they can still be part of it. Separation anxiety, to where they think like, oh my God, don't leave me. I'm gonna die if you leave me. You have all those issues there. You may have some disruption of the vision to where that may not come back to where the eyes were severely damaged. And that just is what it is. Unfortunately, that's part of the explosion in itself. Solid organs are relatively protected from the shock wave, but they may be injured by the secondary missiles or hurled to the body. So you have your penetrating objects that impale the body, or from when they land on that hard surface and that impact is, you may cause a rupture from that. Neurologic injuries and head traumas are the most common cause of death from the blast injuries. Extremity injuries, including traumatic amputations, are common. Sorry, I had to take some water. So this is going to be the traumatic amputation, to where their arm, leg, fingers, hands, whatever is gone. It took the blasted end. It just literally, it took it until it got more solid. If y'all understand what I'm trying to say. So like the ankle is pretty much weak, but you start getting up mid to about mid tib fib. You start getting to more solid areas, so it's easier to stop it at that point. And you know, it just depends on where they were located. They could be, you know, happen on the other side of the vehicle and it blow out both tib fibs because the vehicle stopped it from there. I've seen a couple bits and pieces of that. A lot of arms are susceptible to a majority of that. So multi-system trauma. So we talked about when we said earlier that it involves more than one organ, more than one body system. Sorry, I don't want to mean organ. So head and spinal trauma, chest and abdominal trauma, chest and multiple extremity trauma. So you can have both arms, you know, an arm and a leg. Alert medical control and transport rapidly. This is something And you don't have to call your med control, be like, oh, I've got a trauma. I'm taking it. And they're gonna be like, oh, okay, what'd you call me for? Because that's what your job is to do. And patients have a high level of morbidity and mortality during this because now their body is fighting multiple areas. It's not just saying, okay, now I have injury to the back. I need to just protect that. No, their chest, their abdomen, their arm is missing. All this now the body is going to go into shock a lot faster, and it's going to cause them to decompensate pretty fast because they can be losing blood from many areas. And we only got so much blood, and after that, it's over. It's gone. So the golden principles of pre-hospital care. Your main priority is to ensure that your safety, your partner's safety, that is the thing. And then the patient comes third. I determine the need for additional personnel equipment. We have talked about that from the get-go. You can automatically dispatch them. You can tell, like I said earlier, have your ALS unit slow roll my direction. I'll give you a full report once I get there and request further assistance. Evaluate the MOI. See what you have. Just because the dispatchers tell you something, they only can tell you what they were told. They don't have eyes in the skies. They can't make up information from you. Sorry, I get a minute. They can only go with what they have, and that's it. So they doing the best that they can. But evaluate what you see. Go from there, and let's make a better suggestion and a plan of treatment. Identify and manage life threats. Go with your ABCs. Treat your airway, breathing, circulation before you do anything else. Now let's focus on your hemorrhaging. Okay, what about your airway ventilate? What about your airway? Is it open? Do I need to secure it? Are they unresponsive? Do I need to do the rapid assessment? Yes, you need to do a triage. Let's go from there. Is the patient in shock, and can I fix it? Is this a life-threatening issue that I can fix quickly? No, you're not going to stop shock in minutes, but it's something that you can help maintain. And then spinal mobilization. We always want to protect that neck. If, like we said earlier, some places may allow you to not board them if they're up, moving around, and don't have any complaints of back injuries. If they're already complaining of a back injury, once you get there, then you probably need to put them on a board. That's whatever your policies and procedures state. I can't tell you any different because you need to look at whatever agency you're going to go work for. Definitive care requires surgical intervention. Now, this is where it gets a little crazy. On scene time should be limited to 10 minutes or less. 110% agree to that. What if it's a 30-minute extrication? You can't help that. Now it's going to be, is it easier for me to life flight them out of here, call for air support? And now, because we're going to be, I have literally personally been on a 4-hour extrication. We flew a surgeon out there. We did the first in the state of Mississippi field amputation because we didn't have anything else. We had to do what we had to do. Now, obtaining your sample and your complete secondary assessment, because this is the time you're going to be shitting or getting. That's all I can tell you is you're gonna have to hustle. This is what you got to figure out. This is how you're gonna do it. This is what we got to do. Blah 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 blah. Things get moving fast. Like I just said, consider ALS intercept or air medical transport. If that's something that's going to be greater than this right here on scene time, always consider your air medical transport. If the call sounds bad and your agency doesn't already dispatch an ALS unit, request one. Listen to what your gut says. My gut says this sounds bad. And you know what? When you get there, it'd be like, this is like grandma hit grandpa in the driveway. We can cancel everybody. And it's gonna look, and then you're like, headquarters showed me 2 refusals back in service. I've done that too. But when it came out, you thought that they hit a bus of hemophiliacs and they're all laid over the side of the road bleeding out. Well, by God, I need the whole state to come, So always consider getting ALS, depending on what your gut says on how it comes from dispatch. When a patient has experienced a significant MOI and is critical, perform a rapid physical exam. Doing your rapid physical exam is going to show you and let you see what's there. Just because you didn't remove their shirt, they may have a collapsed lung because now there's a piece of glass sitting in there and you were just lazy and didn't do it. Expose them. Do that head to toe, touch every part of that body. And with respect, let's say that I ain't gonna be trying to fill up in no undergarments or nothing. And I'll tell a guy in a heartbeat, hey, bro, listen, I need you to grab your junk. Does it feel like it's there? Okay, good. Thank you. Let's move on. Put your hand back. That's on them. That they need to know that. If it's one of those, I'm like, ma'am, I need you to make sure that everything's okay. And I hate when they tell you, well, I've had implants. This one leg is busted. Ma'am, this ain't the time. I don't care. It's not for me. It's always going to happen. When a patient who has experienced a non-significant MOI, focus on the chief complaint while assessing the patient as a whole. If I have them on the backboard and they're in a 45-degree position, they're comfortably, they're resting, and they just tell me, I just hurt. I'm going to have them talk to me. I'm still going to do a head to toe assessment on them. And I will note other things that I have found during my assessment. Now, if for some odd reason I find something that they didn't complain about, I'm going to ask them, like, hey, I noticed you're missing your left toe. Does it hurt? Oh, no, I didn't even know it was. Well, guess what's hurting now? Their left toe. So that's now a secondary complaint. So injuries to the head. Now, one thing that you're probably going to see is when they have these injuries to the head, you're going to have confusion. You're going to have I asked the same question 15 times, even though you're going to get frustrated at them. Don't. It's not their fault. They don't know that they've asked you where they're at 10 times. They just want to know where they're at 10 times. You'll notice bleeding or swelling in the skull is often life-threatening. You can look for the raccoon eyes or the battle scars around the neck. Around the base of the ear. Those help you, but it's not saying that you're going to see them all the time. They may not come until later. Some patients who have no obvious signs or symptoms may be your ones that crashed on you before the ones that have their guts hanging out, because you can see that. But the ones that are bleeding in their abdomen, they're the ones that they're going to compensate pretty quick, and you can't do nothing about it because I can't see it to stop it. Area of serious or deadly injuries. Airway problems may result. Look for the decap BTLS in the neck and groin. Assess those. Those have big arteries that run through the neck and the groin. That's why you want to check there. Swelling may prevent blood flow to the brain. If there's an injury to the back, to the neck, you may notice that they may not be acting the same as they were. Why is that? Well, I noticed their neck looks like they're a deer in rut. So what's up? Do you think they look good, or what's the deal here? So be cautious to those. Make those mental pictures when you're assessing your patient, and watch their airway. When their neck starts swelling like that, or they're restricting blood flow, you'll see them gasp more for air, and it'll be quick, because once the airway gets to a certain point, you're like, whoa, bro, why are you not breathing this thing? Why are you breathing like 4 times a minute? That's not good. I'm having to work now. All right, penetrating injuries may result in an air embolism. We talked about that. There are certain things we can do for that, can't do for that. And after that, we're just going to have to roll with it till we get to the best facility. A crushing injury to the upper part of the neck may cause from the cartilages of the upper airway and larynx to fracture. So now you may have neck injuries that's causing a neck injury that's causing a respiratory problem. So if you have a neck injury and now you're having a respiratory issue and they're complaining of that, that's the reason why the money collars are cut out in certain ways, so you can see their neck, you can see their trach, to where if you can notice the swelling, or you can see that midline shift, those money collars have that opening in the holes, and they're designed that way so you can see them. You can keep an assessment on there. Chest contains, obviously, I hope you know what it contains. Many life-threatening injuries may occur. Broken ribs may hinder the breathing. Bruising may occur to the heart and cause an irregular heartbeat. Large vessels of the heart may be torn inside the chest, causing a massive unseen bleeding. Air may collect between the lung tissue and the chest wall, known as a pneumothorax. The collection of blood in the chest is also called as a hemothorax. You can fix a pneumo. They need a chest tube to fix the hemo. So remember the two differences, air and blood, and those will help you out. You can't fix the pneumothorax, but advances and paramedics can. Drop that 14 gauge in the chest and you can see it. If you're in a good place, you can hear it too. Penetrating or perforation of the interior of the chest wall start an open chest wound. If that is left untreated, you're going to die. You will die, no questions asked. That's the reason why it is very imperative that you assess that chest every 5 minutes. If you don't, you're missing out on a critical injured patient assessment. You're not going to catch those things. You're going to miss it. Assessment should include decap BTLS, lung sounds, and chest rise and fall. Touch the chest. Put your hands and assess it. Make sure that you're looking for that snap, crackle, pop when you go to assess. Like when you're running, so when you run your fingers down the chest wall, I make it look like all of my fingers are moving in different ways because if there's air trapped underneath the skin, it's going to sound like snap, crack, like the Rice Krispies when you're assessing that, and you're going to be like, whoa, what was that? I do that the same thing as I go down the arm. I start at the shoulders. I make sure to touch every bit of skin as I'm going down to make sure that I don't miss anything. Plus, it lets me notice if I come across any secondary complaints. Why do I want to know what the chest rise and fall is? Is it adequate for breath? Is it adequate for life? Do they have sufficient chest rise and fall? Is it enough to maintain? Sorry, my son showed me a note. I had to giggle. Abdomen contains vital organs that require a very high amount of blood flow. So you can bleed so much out into your abdomen, it's not even funny. And it will bleed out so much before you even realize you're like, oh God, it's swelling. I don't and if you could have noticed it sooner or maintained the constant flow of the vital signs, you could have possibly flown them out. Hollow organs include the stomach, large and small intestines, and urinary bladder. That would probably be important if you remember those two, and the solid organs. Solid organs include the liver, spleen, pancreas, and the kidneys. Just going to tell you, those are probably test questions. I'm going to knock twice. Solid organs may tear, lacerate, or fracture. Hollow organs may rupture, leak toxic digestive chemicals. Man, it ain't nothing like a busted spleen. You got tons of blood. When they cut you up and take that out, it's just like a flow of blood. It just don't stop. The rupture of large blood vessels can cause serious unseen bleeding. Dissecting aortic aneurysm is part of that. They can part of those can when they dissect, they cause a lot of bleeding. And once that happens, man, I'm gonna tell you, as much as I would love to help you and as much as I can do, you can't do nothing for them. It's just part of it. And that can also happen from MVC, MBA, any type slow high. They may not have known that they had chest issue or heart issues until it happens. And I'm gonna tell you, when that patient tells you, I feel like I'm going to die, take their word for it. Just take their word. When somebody tells you that, period, don't be like, don't let me die, I'm scared to die. That's no, like when they tell you I'm fixing to die, that's it. I've had two people in my career that have had asecting aortic aneurysms. One died as I walked up to him. The other one, I had him for about 5 more minutes. And there's nothing you can do. If he was on the table, been the only way to save him. Scene time. I want you to minimize your scene time for the betterment of your patient. 10 minutes or less if they're critical. And if they're non-critical, you can stay longer, stay and play. Critical injured patients is dangerous MOIs, decreased level of consciousness, any threats to the airway, breathing, and circulation. Patients who are very young and old have chronic illnesses should also be considered a high risk. So the under critical injured patients, those statements that we just said should always be considered to go lights and sirens to the hospital and less than 10-minute on scene time. If you can help it, if it's a greater like uh, extrication time or gaining access to the patient, those things you can't control. But from the time you put your hands on that patient and you have the ability to leave, it needs to be 10 minutes or less. Um, a level one facility. So this breaks down the different levels of facilities and of medical facilities. So to be one of these, you have to have all of the categories. For level one, serves large cities and heavy population areas, provides every aspect of trauma care for adults and pediatrics, usually university-based hospitals. Level two facilities located in less populated dense areas provides initial definitive care. Right now, they're all full with COVID patients, so be careful. And now, level three provides assessment, resuscitation, emergency care, and stabilization. They transfer patients to a level one or two facility when necessary. And a level four found in remote outlying areas provide advanced trauma life support. These are probably going to be the ones that have your nurse practitioners running the ERs, may have a physician on call. He may not be in the ER, but the nurse practitioner is your main point of care provider in the facility. Those are most time your level fours. You are seeing some of the nurse practitioners and a level one, two, three, or four. I am not knocking them. They all have their wonderful places and their abilities. But due to the pandemic, everybody's short, so you're starting to see them everywhere. My state finally approved for emergency use only that paramedics and EMTs can assist in the ER finally, but it's only while the pandemic's going on, which I think is retarded. So AAMS is the Association of Air Medical Services, and Medevac Foundation internationally identified the following criteria for use of appropriate emergency air medical services for trauma patients. So this is pretty neat while you listen to it. So some agencies may follow this, and some agencies may variate between it dependent upon the call. There is an extended period required to access or extricate a patient remote and a trapped patient that they will fly to. The distance to the trauma center is more than 20 to 25 miles. The patient needs ALS care, and there is no ALS level ground ambulance service available with a reasonable time frame. Your reasonable, my reasonable are two different things. Think about that. Traffic conditions or hospital availability make it unlikely that the patient will get to the trauma center via ground ambulance with the ideal time frame. And there are multiple patients who will overwhelm resources at the nearby trauma centers, and the EMS system require bringing a patient to the nearest hospital. So those are the standards that they do and don't fly on. Now, I have had our local facility, our local level one, fly to an officer was shot. He was shot in the neck, and we were less than 15 minutes away from the facility by ground. They flew after being requested because of the officer. It doesn't matter. They would have flown to anybody, but those are some of the situations that you can also think about. Now, again, they may or may not deviate from what is set in place by the AAMS, or they can make it worse. It's all depending. They can say, no, these are our guidelines. We only fly for this, 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 and this. And then you have some facilities that only fly on critical care transports for interfacility transfer. I've seen it. Trauma centers are categorized by either adult trauma centers or pediatric trauma centers. They don't have to do both. Most of your universities will do both, and they have the same level of care for both adult and pediatric. And most of your universities all have accessibility to every language spoke so you can translate to the patient on resources within like a 5-minute wait time. Our facility even has actually one of our dispatchers. She's a very she speaks Mandarin Chinese pretty well, so she can translate if you can get across those issues. Type of ground transports, you have ground EMS units, staff of EMTs and paramedics. I hope you all know that. Air units, most of the time are just ground units, or most of the time has a nurse paramedic. Some facilities do nurse or nurse practitioners, a physician. Every facility in every air transport in my state either flies nurse paramedic or nurse. They don't fly double paramedic because there's certain things, obviously, as you know, that paramedics can do versus nurses and vice versa. A lot of our staff in our areas are dual trained. They can be nurse or paramedic, depending on what role needs to be placed on that patient. I can't see that well. I hope the heck y'all can. So depending upon your transport and your destination, I'm just going to. So step 1, determine your Glasgow Coma Scale. What is your blood pressure and respiratory rate? If it's less than 13, transport to the trauma center. If it's less than 90 millimeters of mercury, and if it's less, I can't, y'all, I'm sorry. I can't read that. Y'all, please read over that. No matter what, these help you make the decision for your field your triage and transportation to what facility. Some of these will help you determine on how soon you need to get to the facility. It's just a guideline. I mean, it's an extra tool to help you. There's a lot of flow charts out there. This is a particular one that just kind of helps you. I can't. I'm not even gonna try to keep reading that. I need to just print that so I can see it. Special considerations. I pray that y'all build good poker faces. I can tell you there's sometimes and I'm like, damn, he's messed up. And then other times I'm just like, all right, dude, let's just go. I don't show my emotions. I've learned that over time. As y'all can probably have learned since we're here, I speak my mind. So when somebody's like, oh my God, I don't want to die. Well, I'm gonna do everything I can for you, but you didn't help the situation that you put yourself in. I sometimes I'm like, God dang it, why did I say that? But sometimes the patients need to hear the truth. Look, I'm gonna do everything in my power to make you get to the facility. I need you to fight with me. Don't fight me, work with me, and we're gonna make this go just as fast. Now we're gonna go really fast to the hospital. Need you to understand, don't reach out, grab anything, don't grab onto me, don't swing at me, and we'll make this a great ride. So never hesitate to call for additional resources. Don't ever hesitate. Anytime that you need assistance, call for it. The best thing that you can do is never cause harm to a patient. Don't injure them anymore. Obviously, if you and your unit isn't an MVC or on the way to the hospital, you didn't help your patient out any better. So think about it. Even though it's critical, it is a life or death emergency that you get there safely. I'm blessed to have not been in a accident while transporting a patient. I have been in accidents while I had no patients on board, but it's something you have to think about and be cautious about. Always do your rapid assessment when it says right there, complete an organized assessment in a timely manner. Make sure that you do your initial and your secondary, your physical, your head to toe. Do those in a timely manner and document that the best that you can. And is there any questions for the evening? Does anybody have any questions, concerns, problems? Want to talk about anything else? Because I know some of y'all have not. Samantha, I see that. I have not seen it yet. But I see that some of y'all have not taken your Mod 3 exam. Please don't rush that. take it in the proper time, but don't rush it, because I don't want y'all to fail it.
I'm just nervous about taking it. Like, I plan on taking mine tomorrow, but just having enough time to study everything, because there's just a lot all in there.
It is chat mod 3 is a lot.
One quick question. Is the exam
talk
going
to
to be open? My bad. I was just going to ask if the exam was going to be open till Saturday, because I have to work at 24 tomorrow.
When did it open? Tuesday night?
I think so.
Tuesday, says Wednesday. I tell you what, I will give all of y'all until Saturday. I'll go in there and change it in a little bit, because mod 3 is so big. So y'all don't feel like you have to rush. If some of you have already taken it and you would like to attempt to redo it, please let me know. But mod 3, y'all, I'm glad you asked that question, but y'all, it's big, so don't feel like you got to rush. I'm glad you asked that question. And I know everybody's like, yes, thank you for asking. I'm really happy, so awesome. So I will open the mod until Saturday night at midnight. How's that?
Thank you.
All right. So, well, then click. This is what everybody wants right there.
I have a question.
Talk to me.
Do they still talk about The Walking Dead? I got up a couple times and had to go out of the room, and I don't know if you went over that or if that's something from years ago, because I was EMT certified like 19 years ago. So
I don't like that movie. I remember that TV show, to be honest. Which one are you referring to?
like the people that walk from accidents that are critically injured but don't act like it. I know you kind of went over a little bit of that.
Yes.
When the adrenaline went up in and all that, but like they can fall and like a minute later be gone.
Yeah, because that energy, you got to think that epinephrine, that epi dump, that fight or flight mode kicked in, and when it stops, that's it, folks. That could be it for them. They don't really teach that as much anymore, but it's a very good point. Yes, I know what you're talking about. That's the reason why I was like, let me see what you're saying before I go there. So, but it's not taught as prevalent as it was 10 years ago. Let's put it that way.
I'm old. I'm sorry. I can't help it.
No,
that was taught years ago. So
I know what you're talking about. So you ain't that old.
Okay.
All right, folks. I'm gonna go in there and I'm gonna change the test until Saturday night. Okay.
Thanks
Y'all
a lot.
have a good night and enjoy y'all's weekend. And don't forget, I fly out Tuesday, so Tuesday night will be kind of rushed to get back in. So y'all have a good one.
All right. Thank you. You too.
Good night.